Go ahead, Dr. Sohail.
Okay, thank you very much, Angela, and thank you very much all the team in the Seattle Science Foundation for giving me opportunity. In fact, not giving me opportunity, giving my colleagues and Pakistan to host this symposium and journal club meeting while in Lahore, and all my colleagues, they are going to present the papers, and then we'll have a discussion. I thank Jens Chapman, who is in Prague. I hope he's having a good time there. It's a wonderful city there, and we miss him. I'm sure he will join there. And I thank all my colleagues in Seattle Science Foundation. And without delay, I'll give you a brief introduction of the topic. What we are going to discuss is various problems in tuberculosis spine, which, as you know, it's not uncommon. We have still tuberculosis, which is still there despite vaccination, etc. And we have still a problem, a plethora of the problem of spinal tuberculosis for various reasons, which are mainly socioeconomic and maybe to a certain extent the malnutrition and poor hygienic conditions. I don't think so. We have significant input from the HIV infection or other disorders, immune disorders. But nevertheless, TB spine and the tuberculosis pulmonary is still there. And we have to deal with various kind of problem from the early childhood to the late, and also people presenting with the late various kind of deformities or neurological problems. And without any delay, I would request we have requested Dr. Hamad and Dr. Ayaz Khan and Dr. Mahmood Ahmed and Dr. Shakil. They are going to present a paper which will highlight their problems and how these issues they are present in the rest of the world, and how they tackle that problem. They will be discussed subsequent to that presentation of their various clinical scenario. So I request Dr. Hamad Sadiq to present first article, and then go on from there to the discussion. He is going to discuss vertebral destruction in a 11-month-old child, which highlights mainly tuberculosis infection in a childhood scenario, which is very difficult situation to manage because of the age, because of the extent of the disease, and because of the growing spine, which increases the deformity to a certain extent. So I think it has a different scenario and ballgame altogether as compared to infection in adults, which is much more understandable and predictable. But in children, it is not very predictable. It is not very easy to handle from the surgical and from the medical point of view. So without delay, I'll request Dr. Hamid to come forward and present his case and article.
Hi everyone. I am Dr. Mohammed Siddiq Hamid, consultant orthopedic and spine surgeon, Lahore General Hospital, Lahore. First of all, I am thankful to my mentors, Professor Tariq Sohail and Professor Hanif, and organizer of the Seattle Science Foundation, for giving me the opportunity to participate actively in this session. Today, I will discuss the carry spine in pediatric age group. Stages of carry spine regarding the progression of disease. There are 4 stages: stages of infection, stages of destruction, stage of deformity, and the stage of healing. Stage of infection is an earlier stage. Infection spread hematologically usually involve anterior paradiscal part of the body. Difficult to diagnose early. Stage of destruction. As infection progresses, destruction of vertebral bodies takes place. State of deformity. Due to collapse of the vertebral bodies anteriorly, there is a kyphotic deformity with gibbous formation. Deformity progresses in pediatric patients depending upon the remaining skeletal growth. More deformity if more remaining growth. Stage of healing. Bony ankylosis ensure with or without deformity if anti-tuberculosis treatment started. Today I will discuss the vertebral destruction in an 11-month-old children with the spinal tuberculosis, a case report and the review of the literature. This article shows the spinal tuberculosis occur mostly in children and young adults. The tuberculous spine lesion in children cases more destruction as most of the vertebral bodies are cartilaginous. The treatment targets are to confirm the diagnosis, eradicate the infection, achieve a decompression of the spinal canal material, and correct or prevent the spinal deformity and possible sequelae. In a study carried out in a Mexican population, all the patients with post disease presented a deformity of the spinal cord at the time of the diagnosis, with an average time of the diagnosis of 8 months, with a range of 1 to 48 months. Similarly, a UK cohort reported a median duration of symptoms before the diagnosis of 7 months, whereas the Taiwan cohort reported a median time of 2 months. Our patient presented neurological deficit and or deformity at the time of diagnosis. Prevalence of these symptoms have been observed more than 2-fold times in developing countries. This is probably because of the lack of education of this syndrome around the population, as well as low economic resources that restrict the access to specialized studies for their diagnosis. In order to get better outcome, in the developing country, it is necessary to promote the dissemination of information in the population. It should be clarified that in Mexico since 1951 and in our setup, the BCG vaccine is part of the vaccination scheme, which is applied at birth, not required dose. The base of the treatment is the anti-tuberculosis medicine suggested for 12 months, starting during the first 2 months and in intensive phase with isoniazid, rifampicin, parazinamide, and the thiambital. Subsequently, a subsequent phase for the remaining 10 months based on the isoniazid and rifampicin at the same previous dose. The destruction of the vertebral body and palate combined with the continuation of the growth in the spine can cause deformity to progress. In 40%, the kyphosis worsens, 40% improve, and in 20% stays constant. Surgery is indicated for complications which such as deformity, neurological deficit, instability, huge abscess, diagnostic dilemma. It should be noted that the growth potential is also disturbed when the disease focus is surgically approached. At the decompression of the spinal cord, the apophyseal ring is partially or completely damaged. Consequently, the growth potential is partially or totally affected. This suggests that posterior elements do contribute to growth and as far as possible anteriorly radical resection should be avoided in children. Now, I want to discuss my case. A 3-year male presented to me previously diagnosed as a case of pulmonary tuberculosis and started anti-tuberculosis treatment by pediatrician 6 months ago. After 1 month, her mother noticed deformity at upper thoracic region, along with complete paraplegia. Radiological and hematological investigation revealed spinal tuberculosis as D5-6 level with complete paraplegia below that level. Radiograph shows spine toppling signs, retropulse, bony fragments, and the facet joints opening, and gibbous formation at D5-6 and D7 level. MRI shows the cord compression. Anterolateral decompression done with tubular strut graft placed anteriorly and transpedicle screw fixation done posteriorly from D3 to D8, with continuation of the ATT. After 1 month, he was able to move his legs and mobilize with cervicothoracic orthosis. It's a post-op radiographs. It's a video. Sorry. Due to some technical error, we can't play the video. Follow-up after 6 months, the patient present with the impingement of the implant. That is the implant failure. It's the proximal screw pull out, and distal screw is the loosening. Now, it's open for discussion for further management. Sir.
Gentlemen, this is Izzy Lieberman from the Texas Back Institute. Interesting case with the 3-year-old child. And what I'd like to know is, did you revise the screw pullout at the top? Have you assessed the fusion since? What's your plan for this individual from this point on?
I think to me, it's not healed as yet. I would go and revise the posterior instrumentation. But again, since if it's a united, the region is healed, disease is healed, the posterior complex will keep on growing. That's the one reason for increased kyphosis and probably pull out. Second is, all these kids, they have a poor bone stock. Their bone is already very soft, and along with the inflammatory disease, this further increases the osteoporotic, and the implant failure or being pulled out is one of the issues which are there. So I think I would assess the state of union, and then if it is still is not fully united or not fully fused entirely, I would go and instrument it again at a more proximal and more distal level, so that mechanically it's much more balanced, and also provides much more stability till the child grows out and defines itself, whether its kyphosis is going to go worse or is going to correct itself, as he's already mentioned. That quite a number of patients, they they grow out into normal, provided their ring apophysis is not damaged by the disease process or by the surgical endeavor. But if it's intact and is still great potential, it may come back to normal, not near normal, but near normal growth with the passage of time. But if there is a cessation of growth potential in that apophysis, then it might remain static and does not grow. In that situation, it will go into further kyphosis, and one can anticipate that over the period of time with a regular follow-up. In the meantime, we'll continue with anti-tuberculosis treatment with the help of a pediatrician who will determine the dose, and the child has to be followed up both radiologically and also from hematological infective parameters.
Fair enough. Do you feel that there's any role for bracing in this case?
I think it is a little high. If you put a brace there, it may or may not help. But if you wish to brace it, then you have to put cervical, and you have to support the chin, so that the proximal thoracic spine or the proximal, cervical spine and the head doesn't not add to the biomechanical imbalance in the face of kyphosis in the upper thoracic area. But again, I don't think so there's any problem in putting a brace, and the brace has to be kind of modified Milwaukee, and since this is only for 6 months or 9 months or 1 year, it will not produce any secondary adverse effects, what you see with a Milwaukee kind of brace.
And I apologize if I may have missed it, but the technical details of doing the anterior corpectomy, how did you access that? Was that a costovertebral approach, or was that a transthoracic approach?
Well, I think what they did is they did a kind of anterolateral approach to the thoracotomy. This is what they did, but if I have to do myself, probably I will not open up the chest cavity, because the chest cavity in this child, which is already known anti-tuberculosis, treatment under pediatrician with a pulmonary tuberculosis, I would have stayed away from the cavity and should have approached the extra cavity approach, which gives a good access to the vertebral body. You can do debrima, you can decompress the spinal cord, and you can put a bone graft. Bone graft in a child is a very difficult issue, because if you use rib is not strong enough, even though it by the age of 1 or 1.5, it gains a good size. But again, the cut ends, they remain sharp. And if there's any deformity there and it's not protected, it may dislodge itself and cause damage to the cord with the sharp ends on the other side of the cut rib. I will use a rib. I will take the rib and put in a sort of unabsorbable or absorbable sutures as a log of wood, and put 2-3 logs of fibular strut and put them in the place of where the corpectomy has been carried out. But during corpectomy, what I would do is I will not aggressively curatize the upper or the lower end of the vertebral bodies, because they are the growth areas, and if you disrupt them, they're already maybe disrupted. But if you disrupt them surgically by putting aggressive curettage or debridement, then you might add to the iatrogenic damage to the already damage which has already happened because of disease process. So I think you just remove the pus, remove any necrotic tissue, sequestrum has to be removed, decompress the cord, and put a bone graft. At the same time, put a 3.5 cervical spine, pedicle screws there in the back, and just protect it. And I think it should be, 2 or 3 level above and below. And since child is growing, I would advise very strongly, and this is in my practice, that I remove the implants after 1 year once the healing has taken place and child is neurologically improved and ambulant. Because if you keep these implants there, it might interfere into the growth of the spine, and it will interfere in the vertebral growth, at least in the level which has been instrumented. Thank you.
This is Jack Ziegler at Texas Back. Just a follow-up question. Do you fuse across the same levels posteriorly to prevent overgrowth, crankshaft of the posterior elements?
I think if the child is too young, and if there's already healing has taken place, that healed segment of the vertebral body will act as a tether anteriorly. And if the posterior structures, they keep on growing, they will add to the kyphotic deformity. In those situations, I will put a bone graft in the back and create a kind of block vertebrae at that level, so that the anterior and the posterior vertebral column, they grow in kind of unison manner, and they do not produce any further aggravation of deformity with the growth.
Thank you.
Thank you very much, Dr. Hamid. Now I request Dr. Ayaz, who is represented by Dr. Kasser, and he's going to talk about caries spine, particularly in the cervical spine, and which is sort of not uncommon scenario in our setup. So I think Dr. Ayaz is going to present case and review the paper in his talk. Dr. Kasser?
Yes, sir. I'm Dr. Kasser, and I will present on behalf of Professor Muhammad Ayaz Khan, my mentor. This article was a meta-analysis which they discussed the current concept in management of cervical spine disease, tuberculosis disease. This was the article which was published in 2021. As cervical spine tuberculosis disease is a rare disease, it is approximately 1% of total TB burden, and about 3 to 5% of all spinal diseases. And there are more greater chances of neurological deterioration, instability, and progressive malalignment in cervical tuberculosis disease. It is a rare pathology. It is divided into atlantoaxial TB and subaxial TB, and the literature evidence was quite scarce, and majority of the issues about cervical tuberculosis disease were controversial. This meta-analysis comprehensively discussed the various aspects in the literature about diagnosis, treatment of patient with cervical spine disease, cervical tuberculosis disease. A thorough literature search was done on PubMed and Google databases. A total of 178 related articles were isolated, and in this study, 41 articles were included, which were review articles, RCTs, and level 1 studies. The upper cervical spine disease involved C1 and C2 vertebrae, which is labeled as atlantoaxial disease, and it constitutes about 0.3 to 1% of all spinal TB. and subaxial TB constitute about 3% or less than 3% of spinal TB. Though the mortality rate has reduced due to modern regimes from 10% to 3%, but there are still high chances of deformity and paraparesis, which are around 15 to 30%. The common clinical features in spinal tuberculosis disease, as you all know, is constitutional symptoms, neurological deficit, and deformity. In cervical tuberculosis disease, the axial pain is about 87%. Radicular pain and neck mobility is also about 80%, and most common 94%, and these are the most common presenting symptoms in subaxial cervical TB. In atlantoaxial disease, in the later stages, there are severe restriction of nip movements and torticollis can also occur. And 70% of the patient with cervical with spinal TB may present with cold abscesses. The prevalence is quite high. The prevalence of neurological compromise is quite high in cervical spine disease as compared to the rest of the spine. And there are even more chances of neurological deficit in adults and elderly patients. The chances of kyphosis development are less as compared to thoracic or thoracolumbar TB because the weight bearing mainly the cervical TB is anterior disease and the weight bearing line is mainly posterior. That's why the chances of kyphosis are less as compared to thoracic and thoracolumbar diseases. The diagnosis is three-pronged, mainly on lab investigations, imaging, and histopathology. The lab investigation include the TLC count, which is raised, ESR and CRP are also raised in about two-thirds of the patient. And ESR and CRP are also of significant prognostic utility as well. And RFTs are important because most of the antituberculous drugs are hepatotoxic. Then there are some immunological tests which were assist in these meta-analysis, and they found that they are also helpful in diagnosing cervical spine TB. Plain radiographs are initially normal in about 3 to 4 weeks. They are normal, but later on there may be disc space narrowing, radic lesion, enhanced vertebral radiolucency, and kyphotic collapse. CT is also important for to demonstrate bony lesions and lesions which are smaller than 1.5 centimeter. The MRI is a gold standard for diagnosing spinal TB, having sensitivity and specificity of 93 to 96%. Respectively, and it is also of prognostic utility as well, and also the MRI can tell us about the status of the card in patients with card compromise and neurological deficit. And also MRI is important to evaluate and to know about the skip lesion and to screen the rest of the spine. This is an MRI sagittal and axial section, which shows features of an active disease having anterior collection and posteriorly card compromise. The C and D picture shows the heel disease in which there is some patency in the canal. Tissue sampling is very important, and they can be procured either surgically or percutaneously under fluoroscopic or image or CT guidance. And all these tissues should be like polymerase chain reaction, and PCR should be done, pathogenic bacterial culture should be done, tubercular culture, and histopathological examination of these tissues is important. In this meta-analysis, some studies shows that the tubercular culture is the gold standard confirmatory test, but other studies show that pathological examination is more superior to the other test and tubercular culture. The principles of management cervical TB is mainly a medical disease. And chemotherapy is the cornerstone of treatment. The first line drugs, as you all know, is rifampicin, ethambutol, pyrazinamide, and the WHO guidelines are, they have divided the medical treatment into intensive phase, which include 4 drugs for 2 to 3 months, and continuation phase, which include 2 to 3 drugs for 7 to 9 or 10 months. Some sort of external immobilization is important, and there are different methods of external immobilization, but the effectiveness of external immobilization is mainly dependent on 3 factors, which are compliance to this external immobilization, age of the patient, and neck mobility while wearing this collar or any sort of immobilization. The general recommendations were that there should be rigid orthosis and avoidance of all activities involving neck movements and weight bearing for greater than 3 months, or until there is definitive radiological evidence of healing. Monitoring the response to anti-tuberculosis drugs is also important, and this is mainly clinical or lab investigation like ESR-CRP should be followed, and radiological evidence of healing should also be present to know about the response to anti-tuberculosis drugs. Also, MRI is a very useful modality for assessing the response to medical treatment, and the MRI T1 weighted images will show increase in intensity, signal intensity within the vertebral marrow, and the T2 weighted images will show complete resolution of granulation tissue and phosphorylation.
Yes, sir. Can
The indication is
go on and tell us about your patient, case which you want to present?
Sir, I put a case in the last, but I will show it in the last. That was an uneventual case. We did anterior carpectomy cage fixation in a patient, 70-year-old, and he had a good result. I will present it in the last.
How long is it? We are running short of time.
It's about 2-3 slides now.
Okay, carry on.
The surgical indications are mainly obtaining tissue samples, spinal decompression, and debridement and stabilization of the spine. This is again another slide showing surgical indication of cervical spine disease. Then a few points about atlantoaxial and subaxial disease. Besides MRI and CT scan, the X-rays which were important are open mouth views, AP and lateral views. That will show some increase in atlanto-dense interval, which is greater than 3 mm in adults and greater than 5 mm in children are important. And surgical indications are more extensive radiological destruction, bony destruction, and significant neurodeficit. These patients will benefit from surgery. Goal and recommended conservative treatment. There are different stages, 3 stages of atlantoaxial disease, and they recommended conservative treatment in stage 1 and 2 disease and surgery in grade 3 disease. Surgical approaches in atlantoaxial disease, mainly it is posterior with occipito-cervical fusion or atlantoaxial fusion. And a few points about they have discussed about subaxial cervical disease. Plane radiographs are important, which shows cervical alignment, and also mainly there are 2 segment involvement. Involvement is a common pattern. C5 is the most common level, and that is followed by C6 level. Surgical indications are C2 to C7 loudness is greater than 0 degree, or C2 to C7 sagittal vertical axis greater than 4 centimeters. These patients have high chances of kyphosis development, and they would benefit from anterior cervical debridement reconstruction. Surgical approaches in these patients is mainly interior, but we can aid posterior approach if there is multiple, if there is need of multiple greater than 2 level carpectomy, or there is junction level or long segment of the cervical spine is involved. And they have there are some protocol about these as well. In grade 1 there is conservative treatment. Grade 2 there is anterior debridement and fusion, while in grade 3 disease combined anterior and posterior approaches are done. Clinical outcome is very favorable, and the response to anti-tuberculosis drugs should be evident in 3 weeks. And they all eventually heal by fibrous union, which leads to ossification and stabilization. And the available evidence in this meta-analysis showed favorable outcome in both conservatively and surgically managed patients. Conclusion of this meta-analysis were that atlantoaxial and subaxial tuberculosis disease constitute 0.3 to 1% and 3% of spinal TB. Respectively, the incidence of neurodeficit in cervical tuberculosis disease is significantly higher than other spinal TB. The general principles of management is similar to spinal TB elsewhere, and medical therapy remains the cornerstone. Surgery is indicated in specific scenarios where there is gross neurological deficit, later stages of disease, or there is disruption, bony or ligamental disruption, and altered sagittal balance as well, or there is poor response to drugs. The surgical approaches in atlantoaxial disease is mainly posterior lawn, while in subaxial disease, it is mainly interior approach, which is more useful, though we can go posteriorly as well if there is multi-segment involvement, and the overall outcome is favorable. Thank you.
Thank you
I
very
will
much.
share another.
Okay, sir. Thank you very much.
Thank you.
I think it's a very, very good presentation, especially the analysis. And I think from the technical point of view, if we divide the cervical spine into a atlantoaxial junction or subaxial, and then is a subaxial spine, and then is a third is a cervicothoracic junction. The occipital-cervical junction is an entirely different joint because they are mainly stabilized not by the bone itself. The bones are shallow. They are not very, they are mobile, but they are not very stable in face of any infection or any other injury. And any infection which occurs either because of tuberculosis or because of sore throat and joining hyperemia and producing laxity, it produces instability there. And this instability in tuberculosis or any other infection occurs very early on in the disease process. And when you can pick up these patients quickly because they have open motor neuron signs very early on when there is just a minor instability and there is a minor laxity and there is instability at the joint, or maybe there is an abscess formation. In those, I think MRI is very important investigation. It gives you the localization of the abscess or any other inflammatory process, and it will also give you the state of neurological elements, and you can treat, very early on before the disease advanced with the instability and with the kyphotic deformity and with the bone destruction. In all this, I think the essence is you have to stabilize, and the stabilization better is from the back, occipital-cervical junction. Depending on the extent of the lesion, one can institute and one can carry on the treatment as appropriate in those. Subaxial is the same, which has already been mentioned. Any tuberculosis it is similar in principle, similar in its presentation with the loss of bone and destruction and kyphotic deformation. One has to identify it. One has to do it again with the examination of X-rays and CT or MR, and one can stabilize it. One should stabilize it. Otherwise, healed kyphosis deformity in the cervical spine, it produces neurological damage because of stretching of the cord over the kyphotic area. And also the approach becomes more difficult because everything becomes sort of glued together in sequelae of infection and all of those sort of things. So I think if you have to go, if there's indications are there, you have to go inside, go early on. You can easily remove the infection and stabilize the spine, putting a plate or other bony material like fibula or any tricortical graft. You can reconstruct the anterior column. Then the cervicothoracic junction is entirely different. It is because of a technical issue that you have to approach the area which is sort of transitional from the cervical to the thoracic. There are a lot of big vessels that are going in, and they sometimes with a short neck and in a fatty patient, the approach becomes even more technically difficult and can, in those situations, I think costotransectomy And the high thoracotomy at the right side is much safer, much more gives you an idea of correction of deformity. And if there are more than two vertebrae, then I think posterior instrumentation is added both in the cervical and also in the cervicothoracic area, so that you can restore the stability, restore the biomechanic, and restore the healthy situation in face of debris and bone grafting, etc. And that with the mechanics are addressed well, then the healing will take place quickly.
Tariq, so this is Jens. I'm in Prague. I may have missed it in the beginning. I'm at the Global Spine Congress here. So when do we know that the TB infection is under control? Did I hear you right that you get serial MRIs? And with hardware, that gets a little bit problematic. Are there any lab parameters? Or how do you know that TB is under control?
I think the patient clinically will be improved with a lot of weight gain. His systemic symptom they are abated. His appetite is improving, and his pyrexia and all those parameters of clinical parameters of tuberculosis infection, they start abating, and the patient gains weight, and neurological recovery occurs. You can take the X-rays. You can take the CT scan, but MRI is not always very good in telling us the progression of disease, because once the signal change occurs in the early process of disease process, they do not show much difference in change in signal in the way of assessment of progression. So if you have to do it, whether infection is still there or not, then PET scan probably will give you much more information as compared to MRI. So I think clinical, radiological, both will tell you, along with the C-reactive protein and lymphocyte count and these sort of things, they tell you the serial evaluation that disease is getting under control or not.
This is Izzy Lieberman again from Texas Back. I just wanted to hear your impression. When I see cervical subaxial TB versus thoracic or thoracolumbar, it seems that the neurologic deficit and the potential for recovery is much less predictable in the cervical than in thoracic and thoracolumbar. Is that your experience as well?
I think I agree with you, because the higher the level of insult is to the neurological tissue, the more it will take time to recover. And the second is, if you have a kyphotic deformation there in the cervical spine, it will acutely angulate the cord, and it will not only impair its vascular supply, but also it will interfere into the CSF flow and the nutritional status of the cord. So I think if you have a kyphotic deformity, whether it's an acute setup or if it's a healed setup, it will induce not only biological but also mechanical factors which will be played into the scenario, and it will produce a local vascular flow, local CSF flow, and mechanical pressure, also the scastrum, all the healed bony tissue in the canal. So they all play their part. And I agree with you. It takes, if the neurological damage occurs, it takes longer time. But I tell you, in tuberculosis, neurological damage, one should correct the kyphosis or deformity as far as possible. They will recover to larger extent as compared to other pathologies. This is my experience. I have done quite a few in cervical and the upper cervical spine. They recover. If you think it's a tuberculosis, go ahead and do surgeries, restore the biomechanics, restore the alignment, and continue with anti-tuberculous treatment. By and large, it will recover in most of the patients.
Yeah, I've always been amazed at the extent of the neurologic recovery, considering the presenting symptoms. They come essentially very paraparetic. They can't walk, move, but a few days, weeks later, you already see quite dramatic improvement. But the cervical ones don't seem to improve as well or as much or as quickly in what I've experienced. But it's interesting disease.
It's a very interesting disease.
In few cases, what I have seen that earlier you pick the disease, the more good is the outcome. And the late you're finding the disease process or diagnosing the condition once the patient is being diagnosed after the interval of 4 to 6 weeks, there are least chances that he will improve over the time, or there are probably even if he improves, whether he will be falling in the Frank scoring C or D. It's almost, and another factor is the age of the patient when he presents with the disease process. The younger the patient and early on the diagnosis is, the better is the outcome, whether it is in the cervical region, thoracic, or the lower lumbar region. So these two are all the time what we have seen, that the earlier you pick the disease process, and the total debridement you have, how the debridement you have done, and how much soft tissue, how you handle the soft tissue while performing the cases. It's not that you have to clearly debride each and every tissue, but you have to respect the vascularity as well. All factors, they contribute to the healing process or to the neurological recovery. Thank you.
Okay, thank you, Dr. Mahmood. I think we should progress and we'll request Dr. Mahmood to present his case and review the details. I would request to, because of the shortage of time, to be as quick and as smart as possible.
Dr. Mahmood, you're still muted.
Yeah. Oh my goodness. I'm Dr. Mahmood, and I'm present here the topic lumbosacral junctional tuberculosis. Next slide.
We're still having trouble hearing you.
Please carry on.
Mahmood, you carry on.
Can you, whether the screen is being shared?
Yes.
Yeah, we can see your screen and we can hear you.
It's not working.
We can see you and hear you both. So go ahead.
Okay.
Carry on.
The topic I am present here, the outcome, clinical outcome, medium term follow the patients with a posterior only approach of the lumbopelvic fixation and lumbosacral for the management of the lumbosacral junctional tuberculosis. This study has been done by the Zhan Xiaozhu and Zhan Zhang at the Shanghai, China. The rationale of the study is to elucidate the clinical features and introduction of the surgical procedure of the lumbosacral junctional tuberculosis, along with the feasibility and the safety of the posterior approach, and assessment of the medium-term clinical outcomes, along with the efficacy of the surgical procedure for the infection elimination and regaining the lumbosacral stability. Globally, the tuberculosis reports global tuberculosis report revealed that WHO in 2018 that 10 million new cases of tuberculosis worldwide in the era of 2018, and spinal tuberculosis, particularly of the lumbosacral junction, it accounts for the 2 to 3% of the total number of the spinal tuberculosis cases. And lumbosacral junction foundation is the foundation of the spine, and making 80% of the lumbar lordosis and lumbopelvic angle having the pivotal role in the sagittal balance. And more than that, global spine balance have been overemphasized from the last few years, and to restore the normal spinal alignment and prevent the late onset neurological damage, and early ambulation and radical debridement along with the chemotherapy have been advocated in the literature. The surgical intervention, it promotes the quiescence of the abscess area and clearance of the lesion, and bone grafting and internal fixation and early stability and stabilization and mobilization of the patient. And clinically, it's helpful in the infection elimination as well. In the past, with the anterior, combined anterior, posterior, and posterior only approach have been used, but routinely what we use is the posterior only approach right now, and this is it's the study which have been pursued right now. What the surgical method have been used in the study is the prone positioning the patient, and then the posterior midline incision where pedicle stabilization with the pedicle screws, and debrema, thorodebbrema, and decompression, and installation of the rods and bone graft and the cage placement. And intraoperative bleeding, these are the outcome years of the 138 patients. The intraoperative bleed was 400 to 1 liter, and VAS score, it have been improved of the period of 2 months pre and post. It has good improvement with a good improvement in the ODI scores, 44 in the pre-op versus 9 in the post-op, and operative time was 2 to 3 hours with the lumbosacral and lumbopelvic angles were well preserved. And the bony fusion was confirmed by the modified Lee criteria, which was quite good as well. And this is a posterior approach. It is less invasive, avoid damage to the vital nerves and blood vessels, early rehabilitation of the patient as compared to the lateral or the anterior approaches, and better construct of the by the pedicle screws, and approach provides better exposure of the anterior part of the spinal canal and posterior decompression as well. And post-internal fixation keep instrumentation away from the tuberculosis focus and conducive to the healing process of the deep tuberculosis. And the medium-term clinical outcomes of the 5 years show that no cases of the tuberculosis recurrence, complete resolution of the infection at the last follow-up, and preoperative neurological deficit had satisfactorily recovered, and there was VAS improvement by the 80%, and there was good bony fusion with no implant failure in the cases. So there are certain cases which have been operated at our center by my own self. This is 37 years old lady which presented with the low back pain, and there was progressive deterioration of the neurology, and patient was on ATT for the 3 weeks, but the symptoms were not improving. The X-rays revealed that there was decreased disk space at the level of L4-5 with the vacuum phenomena as well. MRI revealing the tuberculoma or the showing the altered signals, and patient was operated. It was operated by the posterior only approach. One single stage debridement was done, and pedicle screw fixation with the L3 to S1 with the soft E-lip. As the bone was extremely osteoporotic, we were not going for the mesh cage in this case. This is the same case showing at the follow. You can see here that there is bony fusion at the level of the tuberculoma site or the spondylodiscitis site, and the tuberculosis has have healed up. Patient meet me almost in my last follow-up OPD, and he was fully mobilized, performing his daily activities, routine life. And but in such cases, the ATT is never ever a simple case. The TB spine in the patients who are on the chemotherapy, we met many challenges, and in such cases we keep infectious disease specialists and MDR TB specialists along with us while the patient is on the follow-up. And the second case of 70 years old, it was male with a thin flimsy skin, emaciated look, and he was with the weakness of the both lower limbs, unable to walk. His ATT had been started empirically, and the patient was on presentation with the Frankel grade T. In this case, there was, you can appreciate that there is destruction of the sacrum, involvement of the sacrum and L5 vertebra as well. And in the previous slide, you can appreciate that that the bone was very thin, and it was so osteoporotic that we were even while putting the screw, I was very much scared that how the bone will behave and how the implant will behave in the post-op period. So in this case, I again did the posterior only approach, one single stage debridement with the the porcelain or the other necrotic material was removed, and L4 to S1 fixation was done along with the soft E-lip was done. This is the case which have been operated. In this case, you can appreciate that there is the L4 screws, they have migrated a bit upward, and L5 was migrated a bit down. This patient presented in the late stage with the there was with the L5 nerve root involvement, there was loss of the EHL was almost there was big toe drop dropped over the time. So to me, it was because of the screw might have caused certain damage to the nerve over the time, over the disease process, as there was settling and it was impeding the nerve somewhat. So, but the vascular improved neurology, overall neurology was improved, and patient was started walking independently. And this is the last case. This is 30 years old male with the VAS score. While patient was in the extreme pain, the ATT, it was taking ATT from 2 months, but the conditions were not improving to that very extent. Patient was with a grade D on the presentation, and there. Here, you may elaborate that the disease process is confined to the L5S1 disc, and there was involvement of the inferior end plate in this case. And there is also the height is being reduced of the vertebral disc, and there is phlegmon is being, you can appreciate right here in this case. And this patient percutaneous sauce abscess was drained 2 to 3 times. Sauce abscess developed 1 to 2 times, and the percutaneous abscess drained 3 times. And patient pain relieved and neurology improved by 6 months. In this case, this is the last follow-up. On the last follow-up, you can appreciate that there is compensated lumbar lordosis along with the lumbosacral angle and lumbopelvic alignment is all are quite good. So this is a conservative case, but while treating this conservative case, the problem which I faced was recurrent sauce abscess, and I have to go for the recurrent aspiration, ultrasound guided aspiration of this one. And also there was delay of this patient to the return to the activities or normal routine. What is the conclusion? That one stage posterior debridement along with the interbody fusion on lumbosacral on the lumbopelvic fixation and postal drainage according to the severity of the sacral destruction is an effective and highly safe procedure to treat the lumbosacral junctional tuberculosis in the adults. So if we can manage these cases conservatively, if these and be picked early on, but in the cases where the presentation is the late and there is extensive involvement of the vertebral bodies, then in such cases we have to go for the mesh cage or cage placement and the debridement, thorough debridement and other things as needed in the thoracolumbar junction. But there are dramatic results if the disease process is picked early on. In such cases, we have seen that Frankel C improve within 2 weeks, and within 1 week, patient was again on the feet. Patient on presentation, it was grade Frankel score C, but after the debridement, after 1 week, patient with a normal neurology and started walking again. So one stage posterior debridement interbody fusion, it's a really effective and highly safe procedure to treat thoracolumbar or the lumbosacral junctional tuberculosis. But what challenges we have in such cases, that most of the patients of the tuberculosis, they are malnourished, they have poor bone stock, they have poor healing capacity, and in such cases there is delayed wound healing, extremely osteoporotic bone. Their bone is so flimsy and so thin that we are very much scared that after how the implant will behave. And there is implant impingement in the lumbopelvic fixation and titanium mesh related issues in the osteoporotic patients, which halt us to use them in the cases of the extremely osteoporotic patients.
Mahmood.
Thank you.
Thank you.
Dr. Mahmood, this is Jens Chapman. So thank you for sharing all this. I really liked your approaches, and that article is a very good one. I'm just a little bit surprised that you did not go to the pelvis with your fixation, especially as you stated that these patients are osteoporotic. I'm not saying you did anything wrong, because you actually certainly look right, but we have so much switch towards going to the pelvis when S1 is even remotely compromised. So, and I'm not sure if Izzy, what Izzy sees and has seen in his practice in Uganda, for instance, but I'm just surprised that you didn't go to the pelvis. So maybe we can talk about that a little bit.
I agree with you, Jens. I think in all this scenario, the one should have gone into the ilium because it provides a virgin bone which is good in health, despite that lumbosacral junction is osteoporotic. And in this situation, when the sacrum is involved, even though it's not entirely disease involved, it may be just osteoporotic, But I think ilium, the two anchors in the ilium, they provide much better stable fixation in which you can restore the biomechanics, you can restore the lordosis, and you can make sure that the biomechanics is much more patient friendly. I think the chances of failure, they are much higher if you involve sacrum and you put your two screws in the sacrum, because they will tend to cut out, they will collapse, and they will develop subsequent secondary issues of osteoporosis, and along with the disease process, along with the fixation of the compromised vertebrae. I think
Yes,
I
sir.
agree.
We can use S2LR ILIC screws as well as the ILIC screws. But the issue remains whether how the cage will behave after the thorough debridement, whether the putting up the mesh cage in such cases, what are the results, if any can share, please.
Mahmood, if you address the situation of the lumbopelvic junction in right manner, the cage will not subside, and it will not be cause any problem. Because cage is a titanium, is a good cage you can use along with the bone graft and etc. But if you have to have a stable fixation in the lumbosacral area, because any loss of fixation result into kyphotic deformation, and once a kyphosis begins, either because of a disease process or because of failure of fixation, it will lead to further aggravation of deformity and further aggravation of implant failure.
So we're almost out of time. So I have to just ask for a very quick answer. Dr. Amin Heneen just wants to discuss. Great point, Dr. Heneen. Thanks for always following us. Why does it make sense in a cachectic patient to not just debride the abscess in the first procedure and then bring the patient back in a couple of days or weeks when they're nutrition a little bit better, and then do a reconstruction? So why not split it up? Why do it all in once if you have a very compromised malnourished post? Thank you.
Thank you. I think it's a very right observation and approach. I think in a poorly sick patient, one would stage it, remove the abscess either through the minimal invasive technique, and improve the general condition by giving antibiotics and increasing the nutritional status, and go in a second stage after 4 to 6 weeks time and correct whatever is required to be corrected.
The current concept is the middle path to lease regime, in which ATT have been started for the period of 3 to 3 weeks prior to the surgery. And during this period, the nutrition status have been also been improved by giving the good proteinous diet. And after 2 to 3 weeks, we proceed for the surgery. In all the cases, we have followed the middle path to lease regime. It's in our practice right now.
Izzy, do you want to take us out? Do you want to do some concluding commentaries
Sure.
and questions?
Thank you for that, Jens, and gentlemen in Pakistan. That tremendous cases, tremendous experience. TB is still a tremendous issue on our planet, all around. We still do see a lot of it in North America, particularly in the Midwest, with the various isolated communities that are around, and particularly the Indian reservations. So it's a problem. We have not addressed it adequately medically, and now we're just learning how to address it surgically. This is something that I would say we as surgeons should be regarded as being or being more aggressive with it. When we see it, we should be taking care of it right away. So thank you all for that, and everybody enjoy the weekend.
Thank you, Jens. Thank you, Isidore. Thank you, Jack, and thank you, everybody.
Thank you very much, Mr. Chapman.
Thank everybody. Thank you, friends.
And thank you, Angela, for hosting us and organizing everything. Thank you. Bye-bye.
Thank you.
We appreciate it. Thank you.
Thank you very much.
Thank you.